ladies and gentlemen. Welcome to Reference Point. I'm your host, Dave Coker-Hook. This evening, we're going to be talking about something that's going to impact every one of us. We are 21 days away, as of this taping, from the start of the insurance exchanges that are created by the Affordable Care Act. And we're going to talk about that today because I have three fantastic guests here today that are going to help me dig into understanding more about this interesting topic. And so with me today, immediately to my left, is Kathy Brown. Kathy is an insurance professional, right? You've been in the healthcare insurance industry for a long time, correct?
Over 30 years.
Over 30 years, okay. So you know a little bit about the subject of health insurance. Next to Kathy is Michael Lujan, and Michael had been previously with Covered California, which is California's exchange for insurance activities. Is that correct,
That's
Michael?
right, Dave, yes.
Okay.
The first state to create their state exchange.
Great, and we want to talk about that because that's going to be significant for our viewers here. And then also is Dr. Shane Dormady, and Dr. Dormady is a hematologist and oncologist, and he's here to talk about how this impacts where the rubber meets the road, so to speak.
Absolutely. Been practicing internal medicine, medical oncology, and hematology for about 10 years.
Great. So I want to thank all three of you for coming today because this, I think, is a significant subject. And I want to let the folks out there know that the depth of this topic is pretty extensive. So we're actually going to tape two shows back to back. But I want to start this off by taking a look at this overall, 30,000 foot elevation thing about this. There's this thing called the Affordable Care Act. It was voted in what, 2009? March 2009.
When in effect, March 2010.
And what is the overall objective, or what was the purpose of having this come into play to begin with? Who wants to field that question first? Okay.
I would say the purpose, in a nutshell, is to provide health insurance to all Americans at an affordable price.
Great, which is a very laudable objective, because I know personally when I had a job change situation, and I went from having coverage to being off for several months and going through the COBRA thing, which caused my rates through that mechanism to be significantly higher. And so being able to afford health insurance coverage regardless of your situation, I think is a good thing.
Mm-hmm.
Mm-hmm.
Yes.
Absolutely.
It just seems to make sense, right? I mean, we should have that. And so what's been a problem with the existing mechanisms that caused us to look at this as a country and think we needed to make some adjustments? Michael, do you have any?
Yeah, I think I can jump in on that one. I think we have a medical rate of inflation that's running about 3-4 times the rate of CPI. And
CPI?
Normal inflation, medical inflation runs 3 to 4 times higher. So the cost have been, rate increases for health insurance have doubled in fewer than 5 years.
So when you say the cost of you're just talking about the cost of insurance, or you're talking about the cost of the care?
Well, I'm glad you make the distinction, because I think as consumers learn more about the Affordable Care Act and what's coming, I think they've become to more broadly accept that health insurance is expensive because health care is expensive.
Right.
So when we talk about health insurance premiums, it's impossible to talk about that without addressing healthcare cost.
Right.
But health insurance, where many people who have coverage, more and more people are finding it less affordable.
Right.
They're downgrading into less coverage to the point where they've got $10,000, $20,000 deductibles and plans that don't really cover a whole lot. They become catastrophic plans. So I think we hit a tipping point where more people don't have insurance, and the people who have it are fearful of losing it or feel like they're underinsured.
And I think some of the stuff, I've got a document here that came from a PowerPoint presentation from someone with the Health and Human Services, and they talked about some of the kinds of things, the essential health benefits, okay, which I think makes a lot of sense. One of the things I believe that the ACA is intended to do is make it possible for you to get coverage even if you have a pre-existing condition, which is huge. I mean, that can really create a huge problem for people if they can't get coverage with a new provider because they have a problem from the past. So, which seemed kind of unfair. So this levels the playing field in that regard. Yeah. Dr. Dormady, have you, what are your, with respect to that kind of a thing, it seems to me that this makes a lot of sense for the kind of patients that you might serve.
Absolutely. I have numerous patients where the diagnosis of cancer can come upon them sort of unpredictably. You have many young, actually an alarmingly increasing number of young patients being diagnosed with advanced cancers. And these are some of the patients who haven't paid attention as much to acquiring health insurance, and they find themselves in the terrible position of needing expensive testing, expensive technologies, astronomically expensive medications, and yet no insurance, and now they have to claim they have a pre-existing condition. It's very hard to chase medical insurance after they're diagnosed.
Right. Makes sense. And so having that kind of possibility, because this plan, the ACA has been put in place, is a really good thing. But,
absolutely.
But there are some other, there's some definite positives associated with this. I think, what are some of the other things, Kathy, that they've talked about that are changes in the overall structure that seem to be very positive? Something about maximum limits or something? I don't.
Correct. It's unlimited as far as the insurance companies used to limit how much they will pay out. So if you got that catastrophic illness, they could limit it to $1 million or $2 million or whatever. So part of the law is it is unlimited.
Okay.
So they can't limit that.
And there's something else about children who are still living covered by a parent pass. I don't. What?
Well, one of the laws that passed is that children can be on your health insurance until age 26, where prior it was till age 19, and then they had to prove they were a full-time student. And if they weren't a full-time student and they had a claim, all of a sudden they were not insured.
Not insured. Ah, okay.
If I can just add just the impact of that, I think nationally it's been over 3 million children,
young
people up to age 26 who've been extending coverage under that provision. And yeah, I think the general impact, if you look at or talk to the carriers or the actuaries who analyze what the impact of that is, it's minimal. Mm-hmm. So if you look at a number of the things that have been sort of universally accepted, that's one of them.
Right.
I don't think there's anyone opposed to saying, having young people up to age 26 continue on their parents' plan. Not a whole lot of people opposed to that.
Right. Yeah. And so there's some positive things here. And then now we're looking at the fact that the government has looked to have us create this, what they call an exchange, right? Mm-hmm. And there's a couple of ways that I understand that's to be presented. One is a federally controlled or regulated exchange, and then there are several states, like California, who are creating their own exchanges. Is that correct?
That's correct.
Correct.
Okay. Yeah. So maybe we can talk a little bit about what exactly is an insurance exchange. And I'm going to go to you. Because and primarily because you've been involved in helping to structure the California exchange.
Yeah, and thank you, Dave, for in the introduction clarifying that I'm no longer with Covered California, but I'm happy to speak here today more broadly on the Affordable Care Act and what is happening with other state exchanges, including California.
Be interested in knowing some of that, right?
Yeah. So you're right. There are three options. It was every state had to either build a state exchange, partner with the Fed, or defer to the Fed completely to run their state exchange. California, I think, wisely decided to launch and create their own state exchange. I say wisely because we have a large population that us bundling together with other states didn't make much sense. Mm-hmm. We have a population larger than Canada.
In California?
California is slightly smaller than Poland. Just to put it in perspective.
As far as numbers of people.
Yeah,
right.
58 counties, a lot of diversity, and it made sense that we did our own state exchange. So I think that was wise. I think other states might even find that it was a mistake to defer to the Fed. Because if you're a large state like Texas or Florida, being bundled in with multiple states and having sort of that federally facilitated exchange model, you might have preferred to have your own. So I'm glad California did their own.
Does that have an impact? Let me restart that question. In terms of those states that have chosen to be part of the federally regular
FFE, federally facilitated exchange.
Thank you. Yeah. I won't try to say that.
I've said it a few times.
Are there limitations on volume and stuff like that? Does that potentially impact a given state's ability for its citizens to get the kind of coverage that they would hope for?
No, I don't think so. I think what it means is, to the extent that states have the authority to have slightly different rules. For example, California can define that we're going to be an active purchaser in how we negotiate rates. That means that the state of California and other states that adopted that strategy say that they would negotiate on behalf of the state of California with the providers, with the health plans. So an active versus passive purchaser model, much like how we in California do CalPERS.
Right.
It also says we can define, as a state exchange, how we even define what a small group is. Federally, it's defined as up to 100 employees. In California, we decided to continue with the current California definition, which is 50 employees.
Oh,
So not so little nuances. They're very disruptive to the marketplace if you adopt a federal model, which changes a lot of those.
Sure, if you had a different
rules.
approach, and I can see how that could be a little bit more challenging for the people of that state. Fortunately, we don't have to worry about that here in California.
Right.
California opted to do its own thing.
Right.
So, Kathy, I want to ask you a question about that, because something that I had read was that there are some number of health insurance companies who had been providing services in California who have opted to not necessarily continue those services in California. And I'm not sure if that's accurate or if that actually has any significant impact on the availability of coverages for people here in the state.
Well, there are a lot of insurance carriers still, I mean, as far as the competition, but there have been insurance companies that have pulled out of California, obviously because they're not making money, and so they no longer want to sell health insurance in California. But certainly there's many carriers now: Anthem, Blue Shield, Aetna, United Healthcare, Kaiser, HealthNet. So there's plenty of insurance companies.
Are all of those offerings available everywhere in the state?
Are you referring to the exchange or just outside of the exchange?
Yes.
Outside of the exchange.
Both.
Well, there are other insurance carriers that are regional, but the big players are throughout the state.
Okay.
There may be networks that are not available, like HMOs and that aren't available in all areas of the state. But
in the most rural part of California, you might find no less than 2 health plans to choose from.
Just because
of PPO.
It's always been the way it
like
is.
Kaiser
Right.
wouldn't be available in certain
Right.
parts of
Well, in some
the
place
state.
in Modoc County or something
There you
like
go.
that. Okay. Well, I want to. You used an acronym that I've heard before, HMO, and PPOs and stuff like that. So, Dr. Dormady, are these structures that have been familiar to us as people who are using healthcare and having plans? Are those going to remain out there? Do you know, or
It's my understanding that they are to greater or lesser degrees, but the shift is going to be that, and there have been many communications between providers in our private practice group about figuring out how to bundle payments for a given diagnosis and use that as a way to limit costs, limit expenditures, and say that for a patient with, for example, lung cancer that's advanced to the 3rd or 4th stage, on average, this much money is spent for the patient. So I think the shift will be that rather than the doctors just sort of ordering everything without a lot of thought to how to stretch the dollar for each individual patient, I think some of us are going to be thinking very carefully, maybe more carefully than we had before, about is there really a statistically proven benefit to adding a newer and very expensive drug to chemotherapy regimen X, or am I just doing that to tell the patient, hey, you're getting the latest and greatest? And really, we should be thinking about using the more standard recipes so that they can have a wider array of options as their care progresses.
So that's not a bad thing necessarily. I mean, what you just described as a structure that causes one to think a little bit more closely about what you do or do not decide to offer as a protocol, that's actually a good thing, I would think.
I think it's a great thing. Again, in theory, as some of these ideas are put onto paper, the idea there is wonderful.
Right.
And really to cause you as the practitioner to do some self-examination. Do you really need a PET scan in this instance, costing anywhere from $10,000 to $20,000, or can you not get away with, but is it more appropriate to order a standard chest X-ray?
Right.
That would be, a massive fraction of the cost. So I think the idea is good. My only concern is, as we start to see how payments might be bundled, it's really hard to figure out what the average cost is for a patient with a certain stage of disease, depending on the disease.
I'm not sure I understand what the term bundled payment. Can you explain that to me a little bit?
Well, again, I think a lot of this has not been said. It's sort of like the example I've seen used most often is that, for example, if someone comes into the hospital for a hip replacement, that from start to finish, the average hip replacement should cost X. And I think they're trying to extend that thinking into the field of oncology, where cancer can be divided into earlier stage disease and later stage disease. But I think the area where you'll start to get wild variability is in patients who have more advanced disease, where maybe it's metastasized to other parts of the body. And inexplicably, some patients do wonderfully with standard treatments or the incorporation of newer treatments and can live for years, whereas others have a much more a much poorer prognosis and do more poorly with the standard therapies. So that's where I think it's going to be really hard to start figuring out averages when there's such wild clinical variability among patients.
Got it.
And if you try to set an average, you'll likely deprive certain patients of valuable therapies as they do better, and may have money left over for patients where they do poorly and are not able to use all the therapies.
Got it. I want to give a comment to our viewing audience out there. Just let them know that if you have questions about anything we're discussing here, send those questions in to me at info@referencepointtv.com, and I'll make sure it gets to the right one of these people here to answer that question, because this is a topic that is going to impact you in one way, shape, or form. And if you want to know something more, we've got a panel of experts here that can address it, so please don't forget to do that. With respect to the coverages and things, it is I've got my family physician, it's on such and such a plan through whoever I have. Is it certain that when the ACA thing goes into full effect that I can just keep the same physician? Are there any possibilities I may have to change, or is everybody just sort of in the same bucket?
Well, I guess it depends on if the doctor wants to stay in the network that you're in. I think that people need to be aware with
when you talk the network, you mean whether he's a Blue Cross or an Anthem?
Right,
or
if he's in the provider network of the insurance company.
So
because if you
okay.
don't go to a doctor that's in their network, then you will have higher expenses on that.
Well, moreover, Dave, I think the question is, and using just Anthem as one example, if you have Anthem currently but you move into a new plan, they may have a different network that may be different than the network you have currently.
If through the exchange I select a non-Anthem plan.
Yeah, and I'm just using Anthem as an example. Right. The same would be true for Blue Shield or HealthNet or anyone else. But I think that's the question is make sure what you have now, what you're moving to, maintains the same network, or at least check out and see if your physician's still in the new network.
So come January 1st, 2014, every citizen and resident alien, someone legally present person,
legally documented,
is supposed to participate in this process. But there are some things, if they don't, that will have impact on them. Is that correct?
Mm-hmm. That's correct.
And there are some people that are exempt from that too, I think. I've got a list here that if someone is below a certain income threshold and they don't have to pay taxes anyway, they're covered by Medicaid or something. And so then there's several other classifications.
Part of an Indian tribe.
Right.
Or religious reasons.
Right. But for the most part, you need to do it. And if you don't do it, you get dinged. Mm-hmm. And the dinging is done by our friends at the Internal Revenue Service, right?
Correct.
So Well, let's talk a little bit about what that means financially for someone.
Well, the penalty for not having health insurance for the first year is fairly minimal. It's $95 for the first year, but it does go up, or 1% of your income, whichever is greater, actually. So
$95 or 1% of your income, whichever is greater.
yes,
Okay.
right.
Okay. It could easily be. All right. Never
But
mind.
it goes up to, I think, $395 the second year, or 2% or more of your income, whichever is greater. And then the third year, it's $695 or 3% of your income, whichever is greater. So I don't know what it is after that, though. They're not
Does it
saying
keep
how.
go-
So I'm
so
assuming
the-
it's going to go up.
So what they're
more.
looking at is they're saying, okay, y'all need to participate in this, and there's going to be a financial penalty if you don't, and we're making it easy at the beginning, but it's going to escalate. With the idea being they want it to be painful for you not to do that. But it doesn't mean you have to get something through the exchange, right?
Correct. That's true. The point is to get coverage. And if I can just add, and I'll editorialize a little bit, the individual mandate or the penalties are not punitive. They're pretty mild. I think enough to get your attention, but not so much to break any bank.
Mm-hmm.
I think the point is to get the attention of the consumer to say you can now get coverage that you might before have been blocked from, either due to affordability or pre-existing conditions.
Mm-hmm.
And in California, that's estimated about 2.6 million Californians might qualify for a subsidy. There's a sliding scale subsidy that would help for affordability for many Californians.
If your income is at above X level, you don't qualify for a subsidy, right? But if
So
it's,
that's correct.
right.
So if anyone wants to know if they get a subsidy or not, they can go to the website of Covered California and put in your income, and it will actually tell you if
Today?
what your subsidy would be, and it's very
Okay.
helpful.
I think we have information about that. coveredca.com, I believe, is the
Right.
website, and hopefully they're showing that right now, because that does. And I think that's useful for people to know too, because look, it's not like this is not going to happen. This is going to happen. So every one of us citizens here in this state are going to need to recognize that there is this change coming on, and it might just be advantageous for you to go to the exchange and find one of these levels of plan that makes sense for you, because if you aren't able to have insurance right now, or there's some, it might be a good thing for you. And there's some things we want to talk about. We've got just a couple minutes left in this episode. We're going to do another episode. And, I want to start a conversation here, or drop a hint of what we're going to talk about when we get into the next section of this. But there's the impact on small businesses. And when we talked about something earlier, you mentioned, Michael, about California's perspective on what is a small business versus what the federal perspective is, and ours is 50 full-time equivalents or more or less, or whatever the term is. But I want to get into that and talk about what that means for business, because we got a lot of small entrepreneurial businesses here. Yeah. I mean, I imagine they do a lot of places in the country, but here in California, entrepreneurism is a big thing, and we've got a lot of small companies, especially here
Oh, yeah.
in the Bay Area. These
Yeah.
little tech firms and these folks that are doing all kinds of services for them, etc. And there may be 3, there may be 33 people in this company. Okay, right. And it's highly competitive in nature, and trying to offer something as a way of benefits to your employees is a good thing. So I want to talk about that a little bit as we get into the next segment. I'm just setting the folks up for that. We're not going to discuss that too much at this moment. But all right, so let's go back to this thing about the exchange program. As an individual, if I go up and I'm looking for something, there are different levels, layers of option for me, right? In terms of these, what are they? Bronze, silver, gold, platinum, I think is the way they've structured
the metal
this.
tiers, right?
Right. And what does that mean? What are these tiers represent? Is it represent the kind of coverage you can get, or?
Well, it represents how much the insurance company is going to pay on the value of the insurance. So at the bronze level, they'll pay 60%.
So it's not that the things that are covered are different. It's what percentage of the costs will be, and I assume possibly your deductible.
It's all
Right.
of it.
It's all of it.
Level of
There's a whole
coverage.
Yeah.
If I can, just to kind of put it in relatable terms, right now consumers, when they buy insurance, they may have a $250 deductible, which seems pretty, a rich plan, but the underlying benefits, there could be additional deductibles, or this has a separate deductible, this has a lifetime max, this has a limit, this is in-network only. When you look at it from that point of view, you don't know if you're buying a gold level or a bronze or a aluminum level. And I think what this intends to do is sort of normalize and say every plan in the state, in and out of the exchange, and this is across the country, will now have what's called an actuarial value. It means this plan has the level, the total equivalent level of 60, 70, 80, or 90% coverage. And that's intended to give the consumer some view of, I'm actually buying real gold or platinum or silver.
Okay.
I don't want to say that the plans do so to be illusory or deceptive, but it's hard to compare one plan with another when they don't have that uniformity.
Clearly. I mean, I can speak to that just from the standpoint of my own personal experience over the years here, of when I, looking at plans for my family in terms of, on various jobs I've had.
Yeah.
So if I understand that correctly, what we've done, both within the exchanges, but anything, because you don't have to get insurance through the exchange. You can get it standardly still from Kaiser or whomever.
And actually the plans are available through the insurance companies also, the same exact plans outside of the exchange.
But those coverage levels are going to be uniform in a sense. Okay, good.
Market-wide.
All right. Well, we've got just we have less than a minute left in this segment of the show, so we're going to wrap this up, and I'm just going to summarize what we've talked about a little bit, and then we'll go into the next thing. We've discussed some of the advantages of this program. We've talked about some of the things that are still a little bit uncertain. We want to get into a little bit more of some of those uncertainties in the next section. And when we get into the next episode, we're also going to talk about the impact on small businesses, because that's critical in California. So, Kathy, Michael, Shane, thank you for being here. I appreciate it. And ladies and gentlemen, stay tuned, because we'll see you next time on Reference Point.
Thank you, Dave.